It's going to have a great perspective from one in the profession who understands these firsthand from owning those pharmacies, but also dispensing and taking care of patients. And with that, I recognize my gentleman friend from Georgia, Mr. Carter, for his comments.
Well, thank you, Representative Collins, and thank you for hosting this tonight. This is certainly a very important subject, very important to me personally, yes, but it's more important to our healthcare system. Mr. Speaker, for over 2,000 years, the practice of pharmacy has existed to help people with their ailments. Today, the most common pharmacy position is that of the community pharmacist. Community pharmacists are the front lines of medication, instructing and counseling on the proper use and adverse effect of medically prescribed drugs. However, over the past decade, there have been several issues that have threatened the role of community pharmacists. Being a community pharmacist myself, I know these issues all too well. I believe that there are three main issues that we can address in Congress that will allow the community pharmacists to continue to fill the invaluable role of counseling Americans on the proper use and dangers of prescription medications. First of all, MAC transparency. MAC pricing transparency. You know, when I became a member of the United States Congress and I got involved in government, I jokingly said that if I could learn 10% of all the acronyms in the federal government, I think I will have been a success. And then I got to thinking about it, and I feel a little silly now because there are a lot of acronyms in pharmacy as well. One of those is MAC, M-A-C, Maximum Allowable Cost. Another is PBM, Pharmacy Benefits Manager. Now let's talk about MAC pricing transparency. This is a bill that's being offered, and this is a situation that needs to be taken care of, needs to be addressed. Perhaps one of the most pressing, if not the most pressing, issues facing community pharmacists right now. MAC is a price list. The maximum allowable cost is a price list that lists the upper limit or the maximum amount that an insurance plan will pay for a generic drug. In other words, if you have a generic drug and it's on that MAC list, they're going to tell you what the maximum allowable cost is. That maximum allowable cost may be $10. Now, if you can buy it for $9, more power to you. But if you have to buy it for $11, you're only going to get paid $10. That's why they call it the maximum allowable cost. Each insurance plan sets the maximum allowable cost for the plan. Some states require them to follow a certain policy, if you will, a certain procedure when they set those those prices. Most states don't. And a lot of states that don't, the insurance companies can set it wherever they want to, whatever they want to set it at. They may choose a drug that's only available in a certain area for a certain price that, for instance, Southeast Georgia, I may not be able to get that drug at that price that they set it at because they use the price that's available in the Northeast, and it's not available to us in the Southeast. That's why we've got to have transparency. That's why we've got to have maximum allowable cost transparency. PBMs are supposed to ensure that the cost of the drugs do not rise to unaffordable price levels, which is supposed to allow continued access to medications to Americans and maintain low costs for employers who provide coverage for those employees. And that's very important. They are supposed to set those prices so that their plan's recipients, the ones that are covered, are able to get those medications. And therein lies the problem. A couple of problems. One is what I just explained, that it's not always available at the price that they set. A second is that sometimes the price goes up. And we know that the prices of generics have been going up significantly and rapidly. And when that happens, sometimes the insurance companies, the PBMs, are slow to raise their MAC prices, which means that if I've got a MAC price of $10 and overnight the price of that drug went up to $20, until the insurance company raises the MAC price, I'm still going to get paid $10, even though it's costing me $20. That cannot be sustainable for community pharmacists. community pharmacy is somewhat different from other healthcare providers in that we have a product. We actually have a product that we have to pay for. We have that product. Now, granted, doctors' offices have injectables they have to pay for, and so, and we understand that. But in community pharmacy, we actually have that product on our shelf, and we've got to pay for it, regardless of how much we get paid. The wholesaler doesn't say, well, how much did you get paid for? That's how much we're going to charge you. I wished it worked that way, but it doesn't work that way. The way it works is they've got a set price. If it's $20 and I'm only getting paid $10 for it, I'm losing that $10. Now, some of you may think, well, you can make up that $10, can't you, and charge the patient? No, you can't do that. If they've got a copay, if that copay is $5, that's what they pay. I can't charge them $15 to make up for that difference. That's not allowed. Now, that's one of the things that's leading to the detriment of the community pharmacy, but perhaps an even more important point there is what happens with the patient. Because keep in mind that ultimately what we're talking about here, when we're talking about keeping community pharmacies open, when we're talking about making certain that this provider is available, we're talking about the patients. We're talking about the patients and patient care. If I'm not able to pay for that medication because I'm not getting reimbursed enough, that patient's not going to get the medication. And that's going to lead to even more medical costs. That's why this is so vitally important. In the end, what it comes to is patient care. What's the problem? What's the problem with PBMs, with the pharmacy benefits managers? First of all, there's no transparency. There's no transparency in the contracts with the PBMs. For example, several years ago, Meridian Health Systems, a nonprofit that owns and operates 6 hospitals in southern New Jersey, hired a PBM to help reduce their surging medication costs for its 12,000 employees and their families. This PBM projected that it would slice at least $763,000 from Meridian's $12 million in annual medication spending. Just 3 months into the contract, Meridian was on pace to balloon by $1.3 million. This PBM insisted that it was actually saving Meridian money. It was not. After some investigation by Meridian discovered that this PBM was making huge gross profits ranging from $5 per prescription to multiple times that amount. In one example, Meridian was charged $92.53 on a generic bottle of antibiotics, while the PBM only paid $26.91 to get the prescription filled. That's a profit spread of $65.62. Therein lies the problem, in what's referred to as the spread. The difference between what the PBM actually charged the company and the difference in what they actually paid for it. That's the spread that the PBMs work on. The amount that PBMs charge to small businesses, the customer, or the government under Part D of Medicare can be significantly more than what it actually costs for them to fill the prescription. You know, PBMs don't, as I mentioned, they don't always update their price list in a reasonable amount of time, and this hurts pharmacies. And more than that, again, it hurts patients. There's been evidence to suggest that some PBMs wait until 4 to 6 months to update their reimbursement rates after a drug price rises. There's been evidence of that. I've experienced that. While I was still working, even 10 months ago before I entered Congress, before I became a member of Congress, when I was still running my drugstores, I experienced this. I experienced where a product would go up in cost, yet the PBM would not adjust their price, their cost, their MAC. And we would have months where we were getting paid less than what we were having to pay for the drug. Obviously, that's not sustainable. That business model doesn't work for anyone, regardless of who it is. This leaves pharmacists getting reimbursed for drug prices that could be extremely out of date.